abdominal, we're going to do the abdominal wall. And there are a few key things that when you look at someone's abdomen that would be laying there in a supine position, meaning they're on their spine and you're looking down at their abdomen, you focus umbilicus, linea alba, inguinal region, and the other appendix, Bernie's point. So in this next picture, we're going to show you these points that you're going to be focusing on. So here would be our umbilicus, which is kind of your center point to work around. Most abdominal problems stop periumbilical discomfort. So that's why it's an important landmark. This is known as the linea alba, or the white line. And this line runs from the xiphoid to the pubic symphysis. Significance of it is a good site for surgical entry because you don't damage muscle tissue when you cut through it. You cut into connective tissue, which will heal a lot more quicker and less scar. So that's the importance of the linea alba. Then we mentioned two other terms, ASIS and the pubic tubercle. Well, the significance of that, it's a line, there will be a ligament structure running through here known as the inguinal ligament, which runs from the ASIS of your pelvis down to the pubic tubercle. And clinical significance of it is when you pass this line, you're no longer in the abdominal pelvic cavity, you're now in the lower extremity. As you'll see, when we do vascular, the iliacs will change their name to femoral once they pass that, such as the femoral artery and vein, and the external iliac artery and vein will change its name when it crosses that to femoral. Also, it is formed by the free edge of the external oblique muscle. So the free edge of the external oblique muscle will roll itself over where it's all its connective tissue and create this canal and ligament structure. In the male, this is a very important canal because this is how the testes is going to descend down to make it to the scrotum. And it's also a big site for hernia, which we'll get into in a few minutes. So the other thing we mentioned is McBurney's point. McBurney's point would be if you drew an imaginary line from the ASIS to the belly button or the umbilical. If we come up about a third of the way of that and make a little X and push in the air and there's discomfort, usually the person would have appendicitis. Usually. There's other things you would do. But that would be the focus point of where the appendix should be lying. So you're kind of close to it. Okay, so that's the significance of McBurney's point. It's not a little boat, it's on the ocean navigation. So now let's go into our inguinal structure. So we have the inguinal ligament canal. We're going to have a superficial ring, a deep ring, and then we'll show you the inguinal ring. So we have superficial ring and deep ring. Can you keep it up there? Good. Okay, now in this picture here, we're seeing it. So the deep ring you physically can't see. The deep ring is deep inside the abdominal pelvic wall, and that's how the testes with the spermatic cord get in from the abdominal area and descend their way down to the scrotal sac. How the spermatic cord gets in through the deep ring, and then will surface out through the superficial ring and sit down in the scrotum. Now the superficial ring kind of sits near the pubic tubercle. So when the doctor, especially on the male, says, okay, check it for hernia, turn your hand and cough, because they don't want you coughing on them, what they're feeling is they're taking that little finger and they're coming up behind the scrotum and going right into this canal, just in this fashion here. When you're in that canal, when the person coughs, you just feel muscle contraction around your finger. If they feel something strike the finger, you would have a hernia. That's what they're looking for. So that means something's in the canal. And usually, most likely, it's intestine that herniated down to the canal that it can literally get into the scrotal sac, where if it's so bad, you can put a stethoscope on the scrotum and hear bowel sounds. And the danger of those two things, strangulation of the intestine, strangulation of the testes, both die. So it's not a good thing. So you lose them all. You can lose them all, and you can lose part of your intestine. And so you should fix it. The way you can fix it is surgery. So this is more common in male than female because the female canal closes. She doesn't have a testes descending down. Unless we're someone else, but we can't get into it. Now, the abdominal wall in the front, so anterolateral, is made up of 4 muscles. We went over these when we did muscles. Rectus abdominis in the middle, external oblique, internal oblique, transverse abdominis, and here's your linea alba, dead center. They all hook and insert. So, this is why I talk about the core is so important. And this next picture of a cadaver is seeing the muscles the way they would look.
Why is the external oblique so high?
It likes to be.
Oh, I'm being stupid.
It's this cut.
It's layered.
It's cut. Yeah, they're cut. They're cut through layers to see this. So you got 4 layers that go.
So the transverse is the back wall?
Transverse is deep, the deepest of them all, and it comes around to the front, but they all do. They found that just by trying to work the transverse abdominis only by abdominal hollowing versus core strengthening, it wasn't successful in treating back pain. Is this do core strengthening, which means you work all 4. And what the point I'm trying to show you here is that there's a big space in here, and it's only protected and coated with muscle. There's no bone. No bone at all. Like we talked here, he had bone protection. Bone protection. Spinal cord, bone protection. None. All muscle. Because the lumbar spine is doing a small part in the lower back. So if we look at the posterior muscles, we have 2 that we focus on that makes the wall of the posterior. The psoas iliopsoas, or mainly psoas major, and the quadratus lumborum. So altogether, there's 6 muscles that wall around this abdomen to keep it sound. We call it quadratus lumborum, quadrangle-shaped muscle in the lumbar area, also called quadratus lumborum. That's how it gets its name. And it runs from the 12th rib to the top of the crest. And it plays a big role in lateral flexing, extending. That would be its function. Most commonly pulled muscle, quadratus lumborum. When you get that flank pain right here, like, oh, I pulled it, that's the one you pulled. So that's the muscular to build on. Now we're going to go and divide our abdomen into regions. And these top 3 we're going to pay attention to first, then we'll come back to this one. So we have this line called the subcostal plane, or subcostal line, which is going to run under rib 10, L3, rib 10. Transtubicular line, which is going to go to L5, but it goes to iliac tubercle to iliac tubercle, hence called transtubicular line. Then we have another line that's going to come down vertically, known as the mid-clavicular line, which runs from the mid-clavicle all the way down to the pubic tubercle. Now, hence, when you do this, you break the abdomen into 9 regions. So keep it in mind. Subcostal, rib 10, L3. Transtubicular, tubercle, L5. And here we go. We break the abdomen into these 9 regions. So in this region here, we start near the belly button called the umbilical region. If we go below it, hypogastric. If we go above it, epigastric. If we go lateral to the umbilical region in the left or right, lumbar, which we know is our flank. If we go left or right to the hypogastric to iliac region, or kind of inguinal area. And if we come up to the epigastric and we go left and right, it's known as the hypochondriac. It means below the cartilage, not the crazy person. That's always sick. Okay? And what's good is the person who's sleeping, you can do the sound. You and your surgical team could play tic-tac-toe. Make sure you start in the outside corner so you win. Because you beat little kids all the time, they get very mad. They're very upset. Can I move the slide there? We just stop. No? Oh. So now we put the squares over what organs would be lying over. So when you're in this umbilical region, you're primarily over all small intestine and some of your transverse colon at the superior aspect. So you're really looking at enteritis type of pain, intestinal pain. When we go straight up, stomach. the biliary tree, but the gallbladder is more over to the right. If we go into our right hypochondriac area, or just say hypochondriac area, gallbladder, there's your liver. If we go to the left, spleen. Spleen and liver really don't give symptoms unless they're really swollen like a balloon. So the one that you'd be focusing on would be your gallbladder and hypochondriac. Stomach and the epigastric. And if we go over to the lumbar regions here, you have ascending colon, descending colon, and what else would be tucked right here?
Those are your kidneys.
Kidneys. So kidney flank pain would be here. It's not showing it because we're doing abdomen stuff, but kidneys would be over there too. Kidneys would be in your flank, your lumbar region.
So diaphragm would be in the.
The diaphragm is above it.
Above it, okay. So
Well,
there's
you got
there's nothing in
Huh?
the,
I was gonna say left and right, and on that, this is kidneys, right?
Kidneys.
Yeah.
Yes, that's right, kidneys.
so spleen would be in the left.
Spleen would be in the left hypochondriac. Yes. Just put spleen under those.
Okay. Ascending colon and small intestine. No.
Small intestines in the middle. So ascending colon on the right, descending colon on the left. But what else would be right posterior to them? The kidneys.
Okay, kidney.
Kidneys. So if we come to the hypogastric, we have the bladder. And behind the bladder, we do the right one. So what else would be here if this was a female?
Ovary.
Well, more
Vagina.
giant sense. Well, uterus.
For reproductive.
Right, reproductive would be there. So we'd be dealing with that. Ovaries would be more right on this blue line. So the ovaries would borderline the iliac area with the hypogastric. So if we look at our appendix would most likely be in that inguinal area right here. Name is Bernie's point. Because your ASIS would be here, so it'd be right around here. And on the left, pretty much just part of your sigmoid, descending, turning into sigmoid. So the key ones that would get asked would be your stomach. Where would you put your stomach? Where would you put your gallbladder? Where would you put your urinary bladder? Where would you put your small intestine? Those are the ones I would focus. Because they're kind of easy, there's not much overlap. I don't want to overlap mine because it's going to mess you up. So if you were asked the test question, what region of the abdomen would you find the gallbladder in? And your choice of a hypochondriac, epigastric, where would you go?
The right top,
Hypogastric.
Hypochondriac.
The right top hypochondria.
Yeah, but I don't have right or left here. You just
Sorry.
go ahead.
Oh, okay.
Where would you find the stomach?
The
Epigastric.
yeah.
Where would you find primarily small intestine? Umbilical. Where would you find urinary bladder? Hypogastric. So your choice would be hypogastric. So you understand, that's how you get asked. So don't go too crazy with it. So what I want you to see is go back to the line. So then we see this other line called transpyloric line, which runs from rib 9, L1, rib 9. And the significance of this line is that any abdominal organ that lies on or above it is protected by the rib cage. Now, we'll go back to the picture in a second. So, any abdominal organ that lies on or above the TPI will be protected by the rib cage. So if you look at the picture, so we'll put our TPL a segment, a rib nut. So we're going to go here with it. So that means my stomach, my liver, my spleen, and my gallbladder will be protected. Okay?
So that top line, the top line.
It'd be above this
transpyloric?
line. It'd be right here.
Oh, right back.
Is it stomach, liver, spleen, and gallbladder?
Yeah. Let's go with that. That's what we protect. Okay? So now, next we're going to go into what we call the mesenteries. Let's go to this picture because it's better. The mesentery. So you already looked at the greater and lesser. Well, there's only two we're going to focus on. First of all, why do we have mesenteries? One, anchor our organs. Two, wall off infection into compartments. Three,
The blood vessels.
blood vessels, an easy way, easy access to get blood vessels to and from the organs. So again, anchor, wall off compartments, and quick route to get blood vessels back and forth from organs. So there's the reason we have the two key ones we're going to talk about: lesser momentum, greater momentum.
Didn't you say something about wall-off infection too?
I said that.
Oh, I'm sorry. Oh, compartment, I'm sorry.
The compartments, wall off infection of the compartments.
All right, my bad.
So the important thing, so we take the lesser momentum is known as a ventral mesentery, and the greater momentum is known as a dorsal mesentery. And you ask why? Well, if we take the lesser momentum first, comes off the lesser curve of the stomach, passes through the liver, through your falciform ligament, and anchors to the anterior body wall. Just anchors to the anterior body. Comes on the lesser curve, passes through the liver, and anchors to the anterior body wall, hence it's ventral, so ventral mesentery. The greater momentum comes off the greater curve of the stomach, comes down over the small intestine, then moves back up, passes over it, and then anchors to the dorsal body wall. Hence it's known as a dorsal mesentery, because of where it anchors, its attachment point. So the lesser one attaches to the front, the greater attaches to the back. Then the last thing to discuss before we go into the true canal itself is organs. Well, we're going to break it into the cavity and retroperitoneal. First of all, it's a cavity that was derived from the mesoderm. So we split mesoderm and we formed a coelom, which now becomes this abdominal pelvic cavity, and it's got linings. And if we're lining the wall, we have parietal peritoneum, and if we're lining the organs, visceral peritoneum, and between each organ and layer, there's a cavity known as peritoneal cavity, which is filled with serous fluid to lubricate it. Why? Because it's constant movement of the intestine, constant. So it's constantly lying over itself, moving, and if you didn't have this gooey fluid in there, it would irritate itself. The other thing is this term retroperitoneal. These were organs that developed behind the peritoneal cavity. So they're not protected by the peritoneum. They're anchored right into the posterior body wall. And the examples would be your kidneys, blood vessels such as vena cava and aorta, your adrenal glands, and your gonads. Those are usually known as retroperitoneal organs. So gonads, adrenals, kidneys, vena cava, aorta. Okay? So, 1, 2, 3.
Adrenals, kidneys, aorta.
Vena cava. So, this finishes up now. We've built the cavity to put GI system in. So from here we go to the GI tract. So the GI tract itself does perform 5 major functions to be considered a true gastrointestinal tract. First of all, our construction, we built a tube within a tube, like think of the earthworm. One tube that travels all the way from mouth to anus, the body, and then the outside body wall. Well, same way with us. So in theory, if you're in here, you are not inside the body, you're still in the outside world, because from mouth to anus, it's one continuous tube. And instead of call it epithelium there, we call it endothelium. Similar lining system to protect of what events pass through and don't pass through. So it's a similar structure set up to the way the integumentary system. But to make this work, we have to, number one, have a place where we can ingest food. Well, we have an oral cavity and an oral pharynx, which is designed to ingest food, so we can get the food into us. Then, when we get it in, we have to be able to mechanically break it down. Well, we can because we have the ability to chew and crush and grind the food. And the mechanical breakdown also will take place in your stomach too. When it gets down in there, the stomach will finish churning the food and constantly keep mashing it. So when you chew your food, eventually we're going to have some chemicals pour in, such as saliva, to help moisten it. And we're going to turn this food into a round, liquid, gooey bolus, B-O-L-U-S, a bolus. So the bolus will leave the oral cavity and pass through the esophagus to the stomach. Well, how do we do it? Well, in the oral frames, we have the ability in the skeletal muscle to swallow. Once it gets to the esophagus, from the esophagus, stomach, small and large intestine, it's going to move by smooth muscle contraction, known as peristalsis, or this wave-like movement, to push and propel the food along. So we have propulsion to movement. So eventually we'll get into the stomach. And again, in the stomach, we'll have chemical breakdown between hydrochloric acid and pepsin. And we'll finish mashing this food into a liquid chyme, C-H-Y-N-E, chyme. Liquid chyme. You might have it later on in your notes.
Yeah.
As long as you got it. So when we get into the small intestine now, we have the ability to absorb. So that's the fourth thing, absorption. So between the small intestine for nutrient absorption and large intestine for water absorption. So we have this absorption mechanism because we have lymphatic channels and blood vessels sitting all around this canal. Then we have to be able to defecate out the feces, which we do through our anus, which gives us the fifth function. And what is feces? Feces mainly is undigested material that the body has no use for, such as fibers in the wall of plant-type matter that we can't use. Out it goes.
And you said large intestine for water, small intestine for
Food, nutrition. Okay? And then this is just another summary, skip that. So this is an overview picture of our GI tract from mouth to anus. And we'll go through each organ. Earlier we did this one, so we're going to go from here into the small intestine. And then we'll cover everything we need to cover. There's a nice schematic versus for real. Identical. Not. First of all, before we do anything else, we're going to go to the salivary glands, but we got to go through the histology of this thing. Well, in this integumentary system, our skin, we have three major layers: epidermis, dermis, hypodermis. Well, in the alimentary canal, or your GI system, we have four layers: mucosa, submucosa, muscularis, serosa. So this is kind of like the outer layer. Okay? So the first layer is mucosa layer. This is lining primarily the lumen of the gut, stomach, small intestine, large intestine. Notice it's lined with simple columnar epithelium. Remember that? Because they're a little thicker and they're going to be a little more selective what they let go through. In this layer, we have this outside layer of epithelium, or endothelium because we're inside, and then we're loaded with connective tissue. Usually loose type connective tissue. That's what we further down. And what's significant of this is that means we have a lot of vascular in the area. We're loaded with blood supply. Very vascularized. And lymphatic channels. So we got a lot of blood supply and lymphatic channels for secretion and absorption. So that's the prime function of our mucosa. The submucosal layer now will have glandular type epithelium in there that aid to secrete through the mucosal layer. These things would be glands. See these round things?
Glands.
And that would be lined with what type of epithelium? Simply cuboidal epithelium. Now, also the significance of the submucosa is this is where your nerve plexus is. to power everything. So your nervous system runs deep into this layer. So now between the two layers, we got a great blood supply and a nerve supply to make everything work. So my glands can secrete, my vessels can absorb, and this nerve supply can stimulate them. And as well, it's going to stimulate our next layer, known as the muscularis layer, which is nothing but layers of smooth muscle to propulse the food along. And your final layer is the serosa layer, which is nothing more than a serous membrane, which would be visceral peritoneum. That's your basic histology. If we're looking at the intestine, it would look like this. Same layers, a little different setup because of where we are. If we're looking at the stomach, it looks more like this. The stomach's designed to hold things, crush things, and secrete into it. In the majority of the small intestine, we have all these little villi in there to increase surface area. So let's go further. First of all, the oral cavity. Well, the oral cavity, yes, we talked about teeth before and the tongue, but now we're going to bring in the glands. We've got 3 sets of salivary glands, which is the parotid, submandibular, sublingual. And they're going to pour saliva. These two are going to pour through a similar duct under the tongue. This is going to pour out over the tongue, which is your parotid. And what's the disease you get in the parotid? That would be mumps. Swollen face. Mumps. We need the tongue to push the food down the back of our throat. It's very hard to push it back there without a tongue. So if they cut your tongue out, you're going to shoot.
You really got to swallow.
You really got to swallow hard because you don't have anything to push it back. So the tongue plays an important role, not only helping you talk and stick it out at people, but to help push your food down the back of the throat. So the esophagus we're going to focus on because it's nothing but a muscular tube that connects this oropharynx to the stomach. No digestion takes place in it, but the main one we're going to get now is to the stomach itself. So the stomach is this pouch designed to hold the food and get it ready to enter into the small intestine to be digested. Not many things can absorb through the stomach. Alcohol is one. Aspirin, salicylic acid, ibuprofen will. So certain, that's why they enterococum now, so they don't absorb through your stomach and cause bleeding. But alcohol is a primer that goes right through. So you drink on an empty stomach, you're drunk right away. Stomach has different regions, has the top dome cover known as the fundus. And the only other organ we'll find that has that in the body is only in females, and that'll be in her uterus. We also have the cardia portion, where the esophagus is meeting it, which we call the sphincter. And we also have the pylorix portion, where the stomach meets the duodenum on the first part of the small intestine. We have greater curve, lesser curve. We also have these ridges in there, these muscular hard ridges, folds, which are known as the rugae of the mucosa. And the rugae will help crush and churn the food to get it ready to enter the small intestine. Also in our stomach, we secrete a product called hydrochloric acid. And the stomach acid has a pH of anywhere from 1 to 3. It's very acidic. And the reason we have it, one is to help break things down and prevent infection, but it will convert pepsinogen to pepsin, which is a product used to break down proteins and breaks peptide bonds. All right? So that's our stomach. And it has a coating in there which protects it. And if we break down that coating, we can end up with ulcers. And the belief years ago was this was due to poor diet, eating spicy food, stress, but Now they realize the bacteria is the culprit, or H. pylori. Could stress create the bacteria to become a pathogen? Most likely, because your immune system will depress and it could happen to you. But it's treated with antibiotics today, not just through diet, to get it to heal. If you want to see what it would look like, cut your finger and put a little drop of acid every day on it and see how well it heals. Oh, you can. I know you want to try it. So from here, we're going to go where? To the small intestine, which is broken into 3 key regions. And that's not a good picture, is it? Yes, yes, yes. So the first part of the small intestine, where we first enter, is the duodenum. And the duodenum is approximately 10 inches long. This is where all your enzymes kind of pour into. So it's like the collecting chamber. The next one we go to is jejunum. So when you make the first flexure, moves back up like a J tail, known as jejunum. That is approximately 8 feet long. Then we pass through the last portion of it, known as ileum, which is approximately 11 feet long. So altogether, you have about 20 feet of intestine for nutritional absorption. The key of the small intestine is it's loaded with villi. The village people. Villi. And on top of the villi, we have little goosebumps, which are microvilli. And why do we put these things there? To increase surface area. So you have a lot of absorptive lining. So villi are designed to absorb. Also, we have these circular folds known as plicae circularis. Plicae circularis. The plicae circularis. And why do we have plicae circularis? So when they contract, they increase the surface area. So the plicae circularis, as it contracts, it's a classmate, so we're going to move at a fast pace, to increase the villi to stick out more to increase surface area. And that's known as the plicae circularis. In each villi, we also have a thing in there called lacteal. And all your intestine also, in this submucosal layer, is lined with a product known as malt, which is lymphoid tissue. Mucus-associated lymphoid tissue, the malt. So what I want you to realize is we have a real big presence of a defense in our intestine. Because it's loaded with lymph channels and lymph nodes. A lacteal is nothing but an individual lymph channel that sits within each villi. And they'll pour down into the true lymphatic vessel and take it away to what it's going to do with it to detoxify. So you can see in each villi you have a big blood supply and a lymph supply. And as we stated earlier, the small intestine will end at the ileocecal valve where it meets the cecal. And the ileocecal valve is designed as a one-way valve to prevent the backflow of waste back into our small intestine.